Dr. Vera, a question from Julia. Julia wants to know, when speaking to patients about toxins and fillers, because you mentioned a lot of times these procedures go hand in hand, which procedure would you start with when your patient comes in, and how would you guide the patient to receiving the combination of those two therapies?
Great question. So if you are trying, so your question can be taken one or two ways. So if the patient is coming in for a consultation and you're trying to do in the same day Botox and fillers, I typically start with my fillers, because when you take the next course and we talk about fillers, you'll notice that there's going to be a lot of palpation, a lot of manipulation of the areas around the face. So what you don't want to do is start with the Botox and then your hand is on their forehead and now you're pressing on that product and possibly moving it around. But let's say they come in for a consultation and they ask you, I want to do Botox or fillers, and then another appointment for the other procedure. I would typically start them on Botox just because it's such a night and day type of result. So you really are seeing a nice significant change, so that patient is able to appreciate that change within 3 to 7 days, and then they're more likely to come back for the fillers at another area.
Oh, fantastic. And how would that apply to the marionette lines?
So typically when I work on the marionette lines, I will start with the fillers again, and correct the changes, the volume loss in that area. And then I finish with the neurotoxin in that area.
Oh, fantastic. Ashley wanted to know, traditionally when someone comes in for dermal fillers, they receive a numbing cream known as BLT in a 20-10-10 ratio. Do you use any numbing cream for toxins, or is it not something that is painful for the patient?
So I typically don't numb for neurotoxins. I use a very small gauge needle. So I'm talking about a 31 gauge needle. So typically I do not numb the area. If I have a patient that's very skittish, very nervous, they tell you that they're scared of needles, that they don't do well with the pain, then that patient you may consider wanting to pre-treat them with a numbing cream just to add some comfort.
Okay. Another question from Julia is that if she uses a 1-to-1 dilution, what would be the diffusion area? And would you use a 1-to-1 dilution?
So the diffusion area is very small. I don't have an exact way to describe it for you, except that I would say it's definitely half the size probably of the nickel normal diffusion for the 2.5 cc's. I follow the guidelines of the pharmaceutical company, so I do my standard 2.5 cc dilution, only because if you ever get into trouble, they're going to start asking questions. Okay, how were you diluting it? What did you use to dilute? So you never want to be questioned for doing something off label if you don't have to. So typically I stick to the 2.5 dilution, and clinically that usually equates a diffusion circumference of about the size of a nickel. But if I had to guess, a 1-to-1 dilution is probably going to be half the diameter.
Oh, fantastic. When discussing the depth of each of these intramuscular injections, how deep would the injection be for the glabellar and then the mentalis?
So typically for those areas, I'm probably going anywhere from 2 to 4 millimeters in depth. It really dictates on how bulky that muscle mass is, but on average 2 to 4 millimeters, not deeper. You always want to stay a little bit more on the surface. Like if you are injecting in the glabellar and you feel bone, you're probably too far, because the muscle definitely lies above that.
Okay. And how does that apply to bunny lines as well as bruxism?
So bunny lines, it's a superficial injection. That muscle is paper thin, so superficial injection for that. For the masseter, you're asking the patient to flex and you're physically grabbing that muscle. So again, you can get a gauge of the thickness of that muscle. Typically, you're talking about a muscle no bigger than 1 centimeter in size. So again, your needle is going in maybe 2 to 4 millimeters at max.
Oh, fantastic. You mentioned the importance of photography when patients come in, and documenting and knowing where you stand pre and then post. Do you use any specific apps for before and after pictures and then combining them together?
No, I don't have any specific apps. We actually use an iPhone that we mount on a Halo device so that we have measurements like you're going to take your photo 3 feet away from the back of my door, which is what I use when I take a picture. And then we just do them in the same type of poses. And then really any app that has like a cropping mechanism where you can put side by side. I think the ones that I've used in the past is called PicLab. But now I have a marketing person that kind of does that. So I don't really know if she uses a different one. I have used PicLab in the past.
Okay, another question from Ashley refers to, in order to lift the eyebrows, can you review again how many units and where the injections would be?
Sure. So remember what we're doing. So we are targeting the orbicularis muscle. So that is the muscle around the eyeball, right? And so in order to get that lift, we're trying to lift the lateral superior aspect. So imagine a vector coming in this direction. So if I were to lift right in this area, that's what you want to lift. So if I have a muscle pulling down in that direction and I want it to lift, I'm going to be inhibiting the action of this muscle in the upper lateral corner. So again, you guide yourself either by the eyebrow, but you want to be palpating and making sure that their eyebrow is on that bone. And I put 2 units right underneath the inferior aspect of that bone. So it's 2 units and it's lateral and it's right on or underneath that superior aspect of the orbital rim. So 2 units, guys.
Dr. Vera, 2 more questions just came in. So question from Julia again with the topical cream, BLT. We mentioned there was a 20-10-10 percentage. Is that standard?
Yeah, that's pretty standard.
Okay, fantastic. What kind of pen do you use to mark the skin?
So I like a white pen. In my practice, I actually use a white makeup pen. So you know those white eyeliners? I find that those are easiest to use because you can sharpen them so they don't dry out like this, for example, which is another good pen, but you have to worry about the fact that they dry out very quickly. I like the color white because remember, if you're making marks and if you use a dark marker on your lighter skin individuals, you can actually, you know, it's a tattoo type of technique. So the last thing you want is to inject into your darker dot and then end up not being able to remove that dot. So typically I use white, but of course, if you're treating a skin type 6 individual, you got to make sure that you don't leave them a little white dot. So typically I use my dots as an indicator of where I want to be, but I will inject right next to where my mark is. So I actually don't inject into any particular mark itself.
Fantastic. And if somebody did want to use the disposable marking pens in white, red, or green, there's a company based out of New York, New Jersey area called Viscot, V-I-S-C-O-T, and they provide the derm markers, or you can order from McKesson. Next question, talking about the depth of injection for DAO.
Okay, so again, it's a very thin muscle, so your depth of injection is maybe about 2 millimeters deep. It's going to diffuse into that muscle.
Okay, fantastic. Next question would be, can you show the point for the dispressor angularis oris again?
All right, so remember guys, if we're on the mannequin, we are looking at the lateral commissure. We're coming approximately 1 centimeter lateral. And then I like to measure the mid distance between the lateral commissure and where my jawline sits. So halfway between here to here is about here. And then if I come out 1 centimeter lateral, I'm looking to put my injection right in this area. Right in there. So 1 centimeter lateral to the lateral commissure, halfway between that distance between the angle of the jaw and the lateral commissure of the lip.
Okay. Next question from Mr. Kapoor. is how do you go about recommending skincare regimens to your patients to really enhance not just your toxin treatments, but the overall end product?
So I always let them know, like, guys, this is part of a journey. If we're doing, let's say we're doing Botox. So what got you here? You have wrinkles. The Botox is going to help to soften those wrinkles, particularly if this patient, let's say, has static wrinkles. So that means that they're not making any faces, but the wrinkles are still there. It's just a natural conversation. You say, listen, my Botox is going to help. I noticed that you still have some static wrinkles. So we really have to work on fully correcting and fixing the damage that's already been done. And then I go straight into I, for example, in my practice, offer SkinCeuticals. You definitely want to make sure you offer a medical grade product. I'm never one to push, so I always like to let them know, if you have something at home, listen, use it. It's better than nothing. But when you run out of those products, you're going to come to my office and I'm going to give you something that's better. It's a medical grade product to continue correcting the damage that's already been done. So it's just a natural part of the conversation. I never throw anything down somebody's throat. But once you kind of plant that seed, usually the patient kind of comes around and they know the options. So always make sure you just give them the options so that they feel that they're making that final decision.
Okay. Next question from Bradenton, Florida, Yulia, asking, with social media and with the stigma that people are receiving these treatments a lot earlier in age for preventative maintenance, how do you go about speaking with customers and people in the industry about at what age to start for preventative versus it's already too late, the wrinkles are, pretty
So it's never too late. And it's never too early. So in my practice, we do pretty much every procedure. So even if you're a teenager, I have some sunscreen to give you. You have a facial you can get. So I'm always educating my patient that it's never too early or too late to start taking care of yourself. Obviously, the younger you are, the less you need. So we pretty much have treatments for every age group. So depending on the age and the status of where your skin may be is what's going to dictate what your regimen is going to consist of.
Okay. Next question is, when speaking about the mentalis muscle, how deep are your injections? Are they superficial? Are they deep?
So mentalis muscle is, not super thin muscle, but not a strong muscle compared to the masseter. So my injection site for my masseters are usually going around 2 to 3 millimeters in depth. You can actually grab the muscle so you can physically pinch it so that you can get an idea of how thick that muscle is and gauge your depth from there. But on average, 2 to 4 millimeters.
Okay, fantastic. Okay, next question is, in addition to practicing on friends and family, how else can the skills start to improve in regards to injection technique as well as practice? Are there any other tips or tricks that you use starting out in order to gain more injection practice?
So for Botox and fillers, here, I'm going to tell you a little secret. You don't even have to buy the product. You can technically start injecting with some normal saline. So you can start getting some technique practice in that, with normal saline, just using aseptic technique, you shouldn't get yourself into any trouble. As far as fillers, a great medium to use so that you can practice your technique for injecting is going to be to practice with PRP. Nothing is 100% safe, but PRP has a similar viscosity to our intravascular volume. So God forbid, let's say you got into a vessel, you should be okay with PRP. So that's a great way to start, practicing your techniques for injecting dermal fillers without necessarily feeling like you're, at super high risk.